Thank you very much for the opportunity, and it's very nice to give this lecture after the lamina crevosa problem to show how complex glaucoma is. Those are my disclosures. And today we have the opportunity to talk about vascular abnormalities in glaucoma patients and its association with peripheral vasculopathies, showing that for some patients, this could work as a systemic disease. Let's start with the hot topic that everybody's looking at today, is the foveal vascular zone, which is, for some reason, it seems like it's a good mark for glaucoma and other diseases, inflammatory disease. And why we're looking for macula again in glaucoma? Well, this is a very nice review of Dr. Don Hood showing that whenever you see damage in the optic nerve, the most important place to look is inferior temporally and superior temporally. When it happens inferior temporally, which happens very often, the nerve fiber layer comes from the macula, or could come from the macula, most of them, and they call this more vulnerable area. So this would be a very important area to study, not only the whole optic nerve, but specific this area here. And people are doing that. For example, the group from Michael Koch, he's studying when the central visual field is affected, how is the behavior of the foveal vascular zone compared with the nasal step, according to that more vulnerable area that we showed before. And he's showing that when you have a central defect, the foveal vascular zone is larger and more irregular than what we have from the patient that has just a nasal step. And comparing this with a control, the size of the difference is really, really big. You can have like a double of the size of the foveal vascular zone. It's just a cross-section study. All of those are cross-section study. We don't know how it works as a parameter to evaluate ISSOCT progression. But a lot of studies going on this with this. And when you look for normal tension glaucoma, it's even bigger, the difference. The control and normal tension glaucoma, see how the shape changed and how the size of the foveal vascular zone changed from the control group. And we try to see if those patients with vascular abnormality in the back of the eye has also vascular abnormality on the peripheral vessels. This is really bad. Okay, so there is some evidence that open-angle glaucoma may be a systemic disease with vascular component. I don't think that it works for everybody, but for some patients it makes sense. That's what we're trying to see. Which kind of patients? So we try to characterize the systemic and ophthalmic vascular profile of open-angle glaucoma, and also vascular factors in open-angle glaucoma patients with low versus high intraocular pressure disc hemorrhage. This is our study protocol. We try to do, almost all clinical and image exam and functional evaluation of the optic nerve. And also we perform some rheumatological exams like laser Doppler imaging, nail fold capilloscopy, and also some blood studies. This is the Oct Angiography protocol for optic nerve head, and this is what we perform for Oct Angiography for those glaucoma patients. We try to measure the foveal vascular zone. The person who was in charge to make the measurements was masked for which group the patient is. And we have similar results from what we have in literature. The foveal vascular zone comparing glaucoma patients and normal patients, the control patients, was higher in the glaucoma patients. And there's also a difference in the shape of the foveal vascular zone. This is how we do the nail capillaroscopy. We're looking for hemorrhage, dilated loops, and glomerulus-like abnormalities on the fingernails. And this is very interesting. It's a cold provocative test that you put the hand for 1 minute in 15 degrees Celsius and see the recovery from the baseline. You can see here the open-angle glaucoma, the baseline 10 minutes and 20 minutes. And the control group, it recovers very fast, the control group, but this is not normal tension glaucoma. This is open-angle glaucoma with high pressure. We did find a difference between the baseline comparing with the control group. And here we have the baseline. Actually, even the baseline before the provocative test was different between glaucoma and the control group. But most of the difference occurs at 20 minutes after the test, the beginning of the test. This is the mean, so you can see even at the beginning, before the test, the difference was big between the two groups. And this is the first study evaluating fingertip blood flow using laser Doppler imaging in open-angle glaucoma, reporting a lower blood flow for this specific group. But there's also something that we're very, very interested to look at is disc hemorrhage. We have an hypothesis that for some patients, the vascular theory would be more important than mechanical theory, because some patients with normal tension glaucoma, so they do not have high intraocular pressure, and even though they have disc hemorrhage, and this is quite usual for normal tension glaucoma. We have a lot of normal tension glaucoma patients in Brazil. The biggest Japanese community out of Japan is in my city, São Paulo. So we are used to see normal tension glaucoma in Brazil. Well, we divide the patients that has disc hemorrhage in high pressure disc hemorrhage and low pressure disc hemorrhage with a cutoff of 13 millimeters of mercury. And this is very interesting. Look at the blood flow before for the high pressure disc hemorrhage. The recovery it's very similar from what we have from control. But for the normal tension or the low pressure disc hemorrhage, the recovery, it takes a long time to get the same thing that we have before the provocative test. And we also have this patient with a normal tension glaucoma, disc hemorrhage, that even at the beginning of the test, before the provocative test, there's a huge blood flow abnormality. And this is the difference 10 minutes after from the high and the low disc hemorrhage. What it means? It means that, what does it mean? It means that what we're seeing, maybe it's a different disease, or even if it's not a different disease, the risk factor for each case, it depends on some specific factors that we still not have a clear idea how it works. And this is the difference between the two groups, mainly at 10 minutes for the high pressure hemorrhage and the low pressure hemorrhage. And this is the conclusion. Patients with low tension disc hemorrhage have more peripheral vascular dysfunction compared with high tension disc hemorrhage. Something that I like from topical OCT is that for every scan you have a retinography. There's a lot of signs that we know that it's related to glaucoma that we lose if you only look for the OCT. If you have, for example, disc hemorrhage, that I think it's one of the most important ones. So you have the opportunity for each scan, you have a chance to see how the optic nerve is and to combine all the information. So at least for some patients, mainly with lower intraocular pressure, high vascular abnormality like disc hemorrhage and large foveal vascular zone is associated with systemic vascular dysfunction. We don't know how to treat this patient. We just lower the intraocular pressure. We don't have anything to improve the systemic vascular dysfunction that this patient might have. Oct angiography could be a very important tool to understand and to follow these patients. And quantitative, this is important, quantitative vascular analysis and algorithm to evaluate and follow foveal vascular zone area and shape would be the next step. We don't have this so far. We don't have a way to normalize, have a bank of normal patient, see the patient, follow the patient, see this is increasing, this is not increasing, the shape is changing. So I think this is a very good suggestion to have on the software. It's a better way to evaluate the density of the vessels, the shape of the vascular zone to follow those patients. Well, this is a special thank for my group. Some of them are here. Thank you very much.